Hi, I'm Terry Tropin, and today I'm discussing steps to select diagnosis and procedure codes for an operative report in the digestive system. First, let me tell you a little about myself. I have a master's in healthcare administration informatics from the University of Maryland Global Campus and have RHIA and CCSP certifications. Also, I'm an AHIMA approved ICD-10 trainer. I've taught health information technology at Montgomery College for over 20 years. I've also written books on coding. These books are study guides that summarize the coding guidelines. My books include One in E&M coding, ICD-10-CM, and ICD-10-PCS. These books are available on Amazon and updated every year. In fact, these two have been updated for 2022. This one will be updated shortly. So here is an overview of what I'm going to discuss in this video. We're going to talk about steps to code an operative report. We're going to look at diagnosis coding, looking for any guidelines, looking for any notes, excludes 1, excludes 2, and then go to procedure coding and any guidelines. By breaking down it into a number of steps, you make sure that you come to the right code. So here is the operative report we'll be coding. This actually is much shorter than the ones typically seen, but in a YouTube environment, it's difficult to code a multiple page report. So here's the report we're doing. A 70-year-old female was visiting relatives in the area and was brought to the emergency department, complaining of vomiting blood and having very dark stools that appear to be bloody. The gastroenterologist was called to consult and found a past history of gastric ulcer. Patient is a known abuser of alcohol. In fact, the ER physician notes she seems to be drunk at the time she's being seen. Laboratory results show a blood alcohol content of 0.08. The patient had an EGD 5 months ago showing chronic bleeding peptic ulcer in the antrum of the stomach. At that time, she was placed on medication and warned that this might be a recurrent problem. It should be noted that serial blood counts at that time did not find any significant anemia. She was admitted to the facility. A gastroscopic examination revealed a 4 by 2 centimeter gastric ulcer with visible vessels, meaning bleeding. She was taken to the operating room where open hemigastrectomy with Billroth 1 anastomosis of the duodenum was performed. Okay, so the first step is underlining important words. Operative reports typically include a lot of information that you don't need in order to choose a code. By underlining the important words, you pull out the information you need and do not have to look at the report over and over again. So these are the words that you're going to look for. Words that indicate a diagnosis, a late effect, a sequelae, a residual, a due to, whether there's a metastasis, whether it's primary or in situ, any history of status post, previous, any indication of acute or chronic, and symptoms. Now these are tricky, and we're going to talk about this in a few minutes. Are the symptoms related to the diagnosis or not? That will determine whether or not they're reported. And then of course you look for any procedures, any words that indicate the type of procedure, the approach, or device. So you may be asking, how do I know what I need to select to code? Which words do I need to underline? Well, this basically comes from practice. As you become more familiar with the codes and the guidelines, you'll be more familiar with what information you need to code and therefore what you would need to underline. So underline the words if possible. I know sometimes you're taking a test online. In that case, you can't underline on the online, so have a scratch paper with you and jot down the words that you need. So for this op report, here are the words we need. We don't need to know that she's 70 years old, female, that she's visiting relatives in the area, we don't need to know that. So I underlined past history of gastric ulcer, known abuser of alcohol, drunk, blood alcohol level of content of 0.08, chronic bleeding peptic ulcer in the antrum of the stomach, and also the gastroscopic examination revealing bleeding, okay? And also that they performed an open hemigastrectomy with Billroth-1 anastomosis of the duodenum. So this is what's important, and all the rest of this is interesting and needs to be documented, but doesn't help you with coding. So this is what we came up with. So that page-long op report has been condensed to this. Alcohol abuse, currently drunk. Blood alcohol content 0.08. Chronic bleeding peptic ulcer in the stomach. Procedures, gastroscopy, and hemigastrectomy with Billroth-1 anastomosis of duodenum. So all of that has been condensed down to here. So this is much easier to work with than looking at the whole report and reading it over and over again. Now, the operative report also listed some signs and symptoms, vomiting blood and dark stool. So do you code these? Well, the general coding guidelines, this one, state codes that describes symptoms and signs as opposed to diagnoses are acceptable for reporting purposes when a related definitive diagnosis has not been established. So this means if all you have is the signs and symptoms and you don't have a definitive, meaning final diagnosis, you code the symptoms. Well, in this case, we do have a final diagnosis. So let's look at the second guideline. The second guideline comes directly from Chapter 18, which is signs and symptoms. And these read, codes for signs and symptoms may be reported in addition to related to definitive diagnosis when the sign or symptom is not routinely associated with that diagnosis. Signs or symptoms that are associated with routinely with the disease process should not be assigned as additional codes unless otherwise instructed by the classification. So unless there's a note saying that you should. So the question to ask is, are we surprised that the patient is vomiting blood and has very dark stools? No, we're not, because the definitive diagnosis is bleeding gastric ulcer. So therefore, we're not going to report the codes for these signs and symptoms because they are related to the bleeding ulcer diagnosis. That's a delay. I don't know why that happened. Okay, so let's start with the diagnoses. We've got chronic bleeding peptic ulcer of the stomach, alcohol abuse, currently drunk, and blood alcohol content, sometimes called concentration, 0.08. So this is where we're going to start. A common area of confusion in coding ulcers is the use of the term gastric ulcer, peptic ulcer. Many people assume that a peptic ulcer means the stomach, but we can't assume that. Remember, in coding, you don't want to assume unless the guidelines tell you you can assume. So we can't assume a peptic ulcer is in the stomach unless it's documented. A peptic ulcer may be esophagus, stomach, duodenum, jejunum, ileum. So if all the information you have is that this is a peptic ulcer, use a code for unspecified ulcer. In this case, however, we have it specified as peptic, but also gastric. So we can use a code, a more specific code for gastric. So let's go ahead and find that. We'll look up in the alphabetic index, look up ulcer gastric, which refers you to ulcer stomach. So find ulcer stomach with hemorrhage, since the op report stated chronic bleeding, which refers you to K25.4. So note that there is an indent for bleeding with perforation, but that's not documented. So K25.6 would be incorrect. So the diagnosis so far from the alphabetic index is K25.4, chronic or unspecified gastric ulcer with hemorrhage. Remember, as always, we do not select a code based on the entry in the alphabetic index. There are important notes and tips you will miss if you don't go to the tabular list. So let's look at the tabular list. And here, yes, we do see a number of notes and tips. So there's a tip here that says assign a code with hemorrhage when a gastric ulcer and GI bleeding are documented. So bleeding is diagnosed as, is coded as hemorrhage. You think of hemorrhage as a lot of bleeding, but if it says bleeding, then you can do the code for hemorrhage. So the ICD-10-CM classification assumes the two are related without the provider linking the two conditions. So in this case, you can assume that if it says with hemorrhage or bleeding, you can do a code for with hemorrhage. This is reassuring. This is reassuring to the coder that you can use a code for with hemorrhage if all the documentation says is bleeding. Another tip under K25, a tabular list, reads, for bleeding ulcers resulting from anticoagulant therapy, code D68.32, hemorrhagic disorder due to extrinsic circulating anticoagulant, and an adverse effect code from subcategory T45.5 should also be assigned. Well, this is interesting, but not really related to this specific case, but it's important to check and read all the tips just to be sure. So, under the code category K25, there are some notes. So there's an includes erosion of stomach, pylorus ulcer, stomach ulcer. So here we see it says stomach ulcer, so we knew, yep, we're in the right place. There's also an important note, use additional code to identify alcohol abuse and dependence. That's also important because remember, she was known abuser and drunk at the time she was seen. Now, excludes 2, acute gastritis and peptic ulcer NOS. So if it says there's a gastric ulcer and a peptic and another separate peptic ulcer, you can use a code from K27, but that's not the case here. So we can just move on. Okay, so we've got the K25 code. So let's go to the alcohol abuse. The use additional code note from K25 refers you to F10 for alcohol abuse and dependence. So this case documents abuse, not dependence. So we're going to look up abuse in the alphabetic index, abuse, alcohol with intoxication, because she's drunk at the time, unspecified, which refers you to F10.129. So with intoxication means drunk at the time she's being seen, okay? So in the tabular list, refer to F10.125. Now there's no information to whether it's complicated or not. This is kind of a side diagnosis, so there may be something, but it's not documented. So we're not going to use F10.120. No information about delirium, F10.121, so we're going to stick with this one. So we're going to go to the tabular list and look for F10.129. There's a note under the F10 category, use additional code for alcohol level if applicable, and that refers you to Y90. The blood alcohol level is documented as 0.08, so there you go. We want to do that. Now, you can't find blood alcohol level in the alphabetic index. The Y90 codes referenced here are in the external cause index, which is totally separate, follows the table of drugs and chemicals in the front of your ICD-10-CM book. Now, I've done it too. I've gone in the alphabetic index and says, why isn't that here? Why isn't that here? Forgetting that there's a separate index for external cause. So go to the external cause index and find blood alcohol level, and that gives you Y90.9. Turn to these codes in the tabular list. Oh, you see that the tabular list has these as blood alcohol level, milligrams per 100 milliliters. The documentation, however, uses blood alcohol content, 0.08. So, to convert blood content to blood alcohol, move the decimal point 3 places to the left. So you've got 0.08 grams is equal to 80 milligrams. So the correct code is therefore Y90.4, level of 80. Okay, so just have to convert one to another. The documentation may have it this way, or they may have it this way. It depends. Well, so what does this mean anyway? Well, it's interesting. In 49 out of 50 states and in the District of Columbia, the legal limit for driving under the influence of alcohol is 0.08. So if you have this number, it's important to document because it may have implications, legal implications. This patient wasn't driving, or we don't know whether she was driving, but it may have implications. In Utah, interestingly, the legal blood alcohol level is different. So just a little interesting note about blood alcohol level. Okay, so let's look at the diagnoses we've chosen so far just to make sure we've covered everything. So we had alcohol abuse, currently drunk. Yep, got that. Blood alcohol level. Yep, got that. Chronic bleeding stomach ulcer. Yep, we got that. So we have everything covered. But first, which code is listed first? That's very important in ICD-10. So you have F10.9, K25.4, Y90.4. So in the front of your book, in section 2, there's a selection of principal diagnosis section, whole separate section. This is after section 1. This is after each of the detailed guidelines for each body system, each chapter in ICD-10. So the principal diagnosis is defined as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Right? So why was the patient admitted? They were admitted because of the bleeding ulcers. So K25.4 is listed first. Okay, let's move on to the procedure codes. So what do we have procedures? We have gastroscopy and open hemigastrectomy with Billroth anastomosis of the duodenum. This was surgery, so right away we know the first character in PCS will be a 0, medical and surgical section. So let's do gastroscopy. It looks like the root operation is inspection. Now, if you're not sure, you can go to Appendix B, root operation definitions, and look at the definitions of the various root operations. In this case, inspection is defined as visually or manually exploring a body part. So it's looking around to see what the problem is. And yes, that's exactly what they did. And they give some examples. Appendix B is really important if you're not sure what root operation to use. So are there guidelines related to the root operation inspection? Yes, there are. Guideline B3.11a, inspection of body parts performed in order to achieve the objective of a procedure is not coded separately. Sometimes providers will document an inspection or an exploratory procedures, but also a procedure such as a biopsy or excision. This guideline means that if something else is done other than just looking around, you're not going to code the inspection separately. Think of a diagnostic colonoscopy when a polyp is found and then diagnosed and then excised. So they're kind of looking around with the colonoscopy, but oh, they find something and that is excised. So in this case, you code only for the excision of the polyp, not the inspection. So here's another guideline. This really applies to this case. B3.11c, when both an inspection procedure and another procedure are performed on the same body part during the same episode, if the inspection procedure is performed using a different approach, this is the crux of it, using a different approach than the other procedure, the inspection procedure is coded separately. So in this case, a gastroscopy was performed followed by an open hemigastrectomy during the same episode of care, the ER visit and the surgery. So one was endoscopic and one was open. So this means, in this case, you can report both. So let's go to start with the gastroscopy. So the index gives you the whole code. Wow, 0DJ68ZZ. So this is good, but even so, you should refer to the table on the main part of the PCS book just to be sure. So you have 0 medical and surgical, D gastrointestinal, J inspection, 6 stomach, 8 via natural endoscopic opening, natural or artificial opening that should be, no device, Z, no qualifier. So that all sounds good. So wow, that was easy. So let's move on to the hemigastrectomy. So a hemigastrectomy, this was an open hemigastrectomy with Billroth 1 anastomosis of the duodenum. So you may see the word anastomosis and think, wow, is this a bypass? Well, let's look at the appendix again and look at the definitions of these. Bypass, altering the route of passage of the contents of a tubular body part. So here you see on the picture on the right, you can see the purple arrows. That's taking you, it's avoiding all of this stomach part. So it's changing the flow, okay? Excision, on the other hand, is just cutting out or off without replacement a portion. So that's more what this is, because part of the stomach was cut and then the duodenum and the stomach were rejoined. That's the anastomosis. So that means this is an excision, not a bypass. So in the PCS index, look up hemigastrectomy, or you can also look up gastrectomy. Indented under gastrectomy, it says partial, total, or vertical sleeve. And it says excision, resection, or vertical sleeve. So if you look at vertical sleeve, that is a procedure used for bariatric surgery to reduce the size of the stomach. That's not what was done here. What was done was partial. So that takes you to ODB, 0DB6. So let's turn to that table, 0DB. 0 medical and surgical, D gastrointestinal, B excision, 6 stomach, 0 open, Z no device, Z no qualifier. So the code we come up with is 0DB60ZZ. So are there any guidelines about this? What about the anastomosis? The guidelines say in the introduction to root operations in your PCS book, it says the term anastomosis is not a root operation because it is a means of joining and is always an integral part of another procedure, like bypass or resection with a specific objective. This means the anastomosis is not coded separately, so we have that covered already in the exit. It is assumed that if you cut something out, what's left is going to be rejoined. So that's basically what this is saying. So here's a summary of the procedures we did. Is everything covered? You can go back to the words we underlined. Gastroscopy, hemigastrectomy, yep, everything is covered. Now again, we get back to which code is listed first. There are guidelines for this. Guideline F, which is the very last one in the guidelines, selection of principal procedure. Principal procedure is defined as the procedure performed for definitive treatment of the principal or secondary diagnosis. That means the gastrectomy is coded first. It doesn't matter that the gastroscopy was done first. It only matters which is the more definitive procedure. So you do the gastrectomy and then the gastroscopy. Okay, so here's, again, we'll look at the operative report, and we come up with these codes. K25.4, F10.129, Y90.4, and then procedures 0DB60ZZ, 0DJ68ZZ. And we are done. There is a lot, and it takes some time to come up with these codes. We went step by step by step. Remember that the more you code, the faster you get. You'll be able to complete these steps quickly, or maybe even skip some as you become more familiar with the guidelines. Also, if you underline, highlight, write in notes as you go, it'll make the process easier and faster. Anytime you refer to a guideline, make a note or highlight it so you can find it easier next time. So let's start with some notes you can do in your ICD-10 book. In the tabular list, under K25 category, make a note that peptic ulcer is not a specific site. Circle the tip about hemorrhage, that bleeding and hemorrhage are used interchangeably in the digestive system. Circle the note about anticoagulant therapy. We didn't need it for this case, but you might need it for the next one. Also circle the note about alcohol abuse and dependence. In the tabular list under F10, you could write in that intoxication means the patient is drunk or high at the time they're being seen, right? And you might also circle the about Y90. At Y90, blood alcohol content to blood alcohol level, about moving that decimal over depending on how it is in the documentation to get to the same way that it's listed in the code. You might also draw a line at Y90.4, for this is when it's considered drunk or impaired driving. Okay, in your PCS book, you can also make some notes. Under root operation, under in Appendix B, under inspection, make a note that this is only looking around. You know, if something is done like that polypectomy we talked about earlier, then you're not going to use inspection unless each one is done with a different approach. So make a note there. Circle also guideline B3.11A and guideline B3.11C. And you might also circle or make a note about that guideline F, selection of principal diagnosis. So that's the end of the video. Be sure to look for other videos coming soon, and I also have 2 previous videos on op reports that you might want to take a look at. One's on cardiovascular system and one's on the musculoskeletal system. So if you enjoyed this video, be sure to hit the like button and click on my picture at the lower right-hand side to subscribe. Thank you. I hope you enjoyed the video.